Cervical cancer can also cause pain, cervical cancer can also cause uterine endometrial cavity distension and pain. However, ultrasound is not very helpful in the diagnosis of cervical disease. However, cervical cancer has decreased in the past decades because of the widespread screening with a Papa Nicolau test. MRI actually has had the most impact on preoperative staging of cervical cancer. Most common cause of cervical cancer is squamous cell, and usually cervical cancer spreads locally and through lymphatic invasion. Here's a transvaginal study, retroverted uterus, sagittal view. We can see the endometrium nicely, the fundus of the uterus, and in the cervical area we see this irregular, marginated, heterogeneous mass. And here again we see that the mass had a lot of vascularity. On this longitudinal view we see nicely the cervical canal, but it almost can be seen that there is invasion into the mucosa, and this was a large cervical cancer. Causes of pelvic pain due to ovarian origin depends if the patient is on the premenopausal woman. It's most likely due to functional cysts or hemorrhagic cysts, can be due to endometriosis, pelvic inflammatory disease, torsion, or tumor. Most commonly benign, such as dermoid, can be malignant. In postmenopausal women, the most common cause of pain from an ovarian origin is cyst or tumor. And the most common tumor, benign tumor, would be a fibroma, or another common cause of ovarian tumors are malignant tumors. Functional cysts seen in premenopausal women. These include follicular, corpus luteum, and theca luteum cysts. The follicular cyst occurs when a mature follicle fails to ovulate or involute and should not be diagnosed till it's greater than 2.5 centimeters. The corpus luteum cyst results from failure of absorption or excess bleeding into the corpus luteum. The theca luteal cysts are the largest, and they're associated with high levels of human chorionic gonadotropin. These are associated with gestational trophoblastic disease. Probably the most common cause of pelvic pain in the premenopausal woman is a hemorrhagic cyst. This is internal hemorrhage into functional cysts. These patients present with acute pelvic pain, and they actually probably can tell you exactly when the pain occurred. Sonographically, the findings depend on the amount and the time of hemorrhage relative to the ultrasound done. In acute hemorrhage, usually the hemorrhagic cyst will present as a hyperechoic, mimicking a solid mass. The posterior wall will be smooth, and many times it will have posterior acoustic enhancement. As the clot hemolyzes, the hemorrhagic cyst becomes more complex, and a reticular pattern develops, which contains tiny little septations. No flow will be seen within the mass. Occasionally you'll see free fluid, and that's due to leakage or rupture of the hemorrhagic cyst. And this is typical findings of hemorrhagic cysts. On the left you can see a hemorrhagic cyst, very homogeneous. We don't see very well the ovarian tissue surrounding it because it's so large. And here's another patient on your right which has a typical reticular pattern. When you see this reticular pattern, it can be nothing else but a hemorrhagic cyst. Postmenopausal women can also present with cysts. They're seen in 17% of all asymptomatic women. 90% are less than 3 centimeters. The important thing here is 53% of these cysts will disappear totally with time. The rest will either decrease or increase in size, but there's really no relationship between these cysts, age, weight of the patient, parity, or hormone use, or the length of time for menopause. What do you do with these cysts in postmenopausal females? Well, they're prevalent. They're usually seen in 5 to 8% in one study, and they're usually measured between 20 to 50 millimeters. But in the literature, it has been shown that the risk for malignancy is less than 1%. The only time that it's worrisome is if you do see within the cyst small mural nodules. If no small mural nodules are seen, then you can follow this management. If they're 1 to 3 centimeters, they do not need any follow-up. You may want to do a CA125 level. If they're between 3 to 5 centimeters, you may follow them. Nobody knows exactly when you should do a follow-up ultrasound, probably in a year. You may also want to do a CA125 level in these patients. If they're between 5 and 10 centimeters in diameter, they're usually still benign. They may be associated with a low malignant neoplasm. You may want to consider laparoscopic removal if the patient is clinically stable. Endometriosis, another very common cause of pelvic pain in the premenopausal women. Endometriosis is functional endometrial tissue outside the uterine musculature, implanted on the surface of other organs in response to the hormonal stimuli. It's most frequently seen in the ovary, uterine ligament, may be seen in the pouch of Douglas, pelvic peritoneum, fallopian tubes. Less frequently in the bladder, cervix, or vagina, but can also be seen in abdominal scars after C-section. Endometriosis occurs in women in the reproductive years, between 25 years and 29 years. 7 to 10% of the population has endometriosis, and it's the cause of 20 to 50% of infertility in women. Tenfold increased risk of women with first-degree relatives. And the symptoms, the most common symptoms are pain and dysmenorrhea, dyspareunia, abnormal menstrual bleeding, and infertility. Pain is not correlated with the extent of the disease, and imaging is very limited in these patients. Here's a nice case of endometriosis, which is usually bilateral. This is a transverse view, transabdominal, the uterus, and 2 bilateral hypoechoic masses. On transvaginal ultrasound, you can see better the morphology or the echogenicity of these masses. This was very hypoechoic, homogeneous. Looked very similar to the hemorrhagic cyst I showed you prior. Transvaginal ultrasound has a high sensitivity and specificity for diagnosis endometriosis, and the reason is identification of an endometrioma, which is occasionally referred to as a chocolate cyst, may be seen. The ultrasound findings of an endometrioma are nonspecific. The mass may be cystic with diffuse low-level echoes, as I showed you prior, as seen in this image. It may be multilocular with thin septations and irregular walls. It looks just like a hemorrhagic cyst. However, hemorrhagic cysts usually have that reticular pattern, free fluid, and decrease in size over time. These may not change at all in time, and usually you will not see that classical reticular pattern. MRI can be used to diagnose endometriosis. And when would you use MRI? Well, when the ultrasound findings are equivocal, or for diagnosis of superficial peritoneal implants, extraperitoneal lesions, lesions in the rectovaginal space, urosacral ligaments. On MRI, an endometrioma has a high signal T1 weighted, and it loses the signal on T2 weighted, referred as the shading sign. And this is due to the high protein and iron concentration from recurrent hemorrhage. The sensitivity of MRI in diagnosing endometriosis is 90 to 92%, with a specificity of 91 to 98%. Well, what do you do with women, premenopausal women with ovarian cystic lesions? Simple or minimally complicated cysts under 5 centimeters are usually physiologic and may need no follow-up. Hemorrhage without vascular soft tissue component is usually a reliable indicator of benign lesion. However, if there's any question about the imaging features, you can recommend a follow-up ultrasound 1 or 2 menstrual cycles, in 1 or 2 menstrual cycles. Usually you want to do it in the early proliferative phase of the cycle. And if that doesn't help, you can always do a CT or MRI, especially in cases that you are questioning dermoid cysts.